With these newer drugs that are coming out, do you think that most of the developments, Dr. Horn, are in end-stage lung cancer? Is that where we're seeing the most sort of bang for our buck with the newer treatments, that survival is being improved in patients with more end-stage disease or advanced disease?
End stage can really be from the time of diagnosis, so not after multiple therapies. So for a lot of drugs, they first get developed in patients with advanced stage disease. And once we see the success in patients with advanced stage disease, we'll see them taken to earlier stage disease and see if we can improve cure in patients with early stage disease. So right now, yes, the progress is being made in patients with advanced stage or end stage disease, as you say, but I think with time we're going to see improvements in early stage disease as well.
Now that we have these newer immunotherapy treatments available, does that mean that you're more likely to prescribe these medications for maybe older, sicker patients that might not have done so well with the traditional chemotherapy regimes? Is it opening up the spectrum of treatment to more patients as a result of better side effect profile?
So I think both immunotherapy and targeted therapies have been easier to administer in patients with more comorbid disease. But we have to remember we've got to select the right patient and give the right drug in the right order. So for patients, if they're just too sick to even get out of bed and come for therapy, I still don't think that those are patients that we should be treating with systemic therapy, and we should continue to involve palliative care and with discussions of goal of care and focusing on quality of life. But it's definitely been easier to give these drugs to patients with multiple comorbid illnesses because the toxicity profiles are so much easier to manage.
And when a patient asks about targeted therapy, how do you educate them about what actually targeted therapy means? How would you have that conversation with a patient and their relative?
So what we will generally tell them is we're going to do molecular profiling of your tumor and do PD-L1 testing. And based on the information, we're going to get back what is the best therapy for you. When we talk about targeted therapy, I explain that it's not traditional chemotherapy, that there is something that's making their tumor grow, and that by giving this targeted therapy, we're sort of turning off the light switch, and their tumor will stop growing and will often shrink. We also have to temper expectations. So we know with targeted therapy, you can often get dramatic shrinkage of the tumors. But I do tell patients shrinkage or staying the same size is success, because on subsequent scans, you're not going to see more shrinkage. You're going to get that maximum shrinkage with that first scan. But as long as we don't see growth, we consider the treatment to be working and continuing on the therapy.
So explaining to patients what scan findings mean so that they really understand that stable disease doesn't necessarily mean that they're not cured.
Absolutely, absolutely.
And with radiation, we've heard that radiation has a role not just for treating the primary tumour in its more advanced stage, but also radiation for tumours that have gone beyond the chest. Can you talk a little bit about how you see the future of those treatments for patients who have disease beyond the primary chest site?
Well, one of the main indications for radiation in patients with metastatic disease is brain metastases, because we know that they can cause havoc very quickly. There's not a lot of room to grow. Patients can become symptomatic, and it can really impact their quality of life. So if a patient presents with brain metastases, we are very eager to treat that sooner rather than later. Sometimes in very good performing patients, that may include even neurosurgery, but oftentimes it involves radiation therapy. And with very few metastases to the brain, we will often do very focused stereotactic radiation. In other settings, radiation in patients with advanced or metastatic disease is palliative, relieving pain. However, as patients start to live longer and longer, the addition of radiation therapy in oligometastatic patients, that's patients with few metastases, can improve their progression-free survival and perhaps give them that chemotherapy holiday that they may need, give them a break from toxicities. So as our systemic agents improve, I do believe that the importance of local control and radiation therapy will grow.